Mr. Chairman, dear colleagues, thank you for the invitation. It is a great pleasure and also the honor to have a talk at this distinguished meeting. The topic of my presentation is going to be medical management of female with luts-induced sexual dysfunction. First things first, sexual dysfunction classification. Sexual dysfunctions are classified into low sexual desire, sexual arousal disorders, orgasmic disorders, and sexual pain disorders. On the other hand, there are lower urinary tract symptoms, which include storage symptoms, voiding symptoms, and post-micturition symptoms. Storage symptoms encompass urgency, nocturia, frequency, and urinary incontinence. Voiding symptoms include hesitancy, spraying, poor flow, intermittency, straining, and terminal dribble. And post-micturition symptoms include post-micturition dribble and feeling of incomplete bladder emptying. The most bothersome symptoms is urgency. However, the underlying cause of these symptoms might be a very diverse group of diseases, like inflammation, overactive bladder, cancer, stones, metabolic diseases, neurogenic diseases, gynecology disease, endocrine diseases, or even adverse events of medications. The current concept of UTI stratify urinary tract infections into uncomplicated ones and complicated ones. Uncomplicated infections are associated with low risk of urosepsis, and complicated urinary infections are associated with high risk of urosepsis. Uncomplicated UTIs are defined as urinary infection in non-pregnant women with no known relevant anatomical, functional, or functional abnormalities within the urinary tract or relevant comorbidities. Complicated UTIs are urinary tract infections in pregnant women, patients with relevant anatomical or functional abnormalities of the urinary tract, patients with indwelling catheters, renal diseases, or with concomitant immunocompromising diseases such as diabetes, for example. Current definition of recurrent UTI is at least 2 bacteriologically confirmed urinary infection within the last 6 months, or at least 3 UTIs episodes during the last 12 months. There is also entity of catheter-associated UTIs, which is urinary infection in women with urinary catheter or who has been catheterized within the last 48 hours. And there is also entity of urosepsis as a life-threatening organ dysfunction caused by UTI. How shall we treat the urinary tract infections? The current EU guidelines says that uncomplicated cystitis is significantly better treated with antibiotics compared to placebo. However, aminopenicillins and fluoroquinolones are no longer suitable due to increased resistance. So there are some antibiotic regimens, and as a first-line treatment for uncomplicated cystitis is recommended fosfomycin, 3 grams as a single shot, nitrofurantoin, 100 milligrams for 5 days, pivmetsilinam for 3 to 5 days. Alternatives include cephalosporins, or if the local resistance for E. coli is less than 20%, we can consider trimethoprim or cotrimoxazole. We should avoid trimethoprim in the first trimenon of pregnancy, and we should avoid cotrimoxazole in the last trimenon of pregnancy. How can we deal with prophylaxis in recurrent UTI? The basis is to get rid of active urinary tract infection with antibiotic treatment, which have just been described. Then we can consider behavioral modification, non-antibiotic prophylaxis, which include hormonal replacement with estrogen, immunomodulation with OM89, probiotics, especially with lactobacillus species, like Lactobacillus rhamnosus or Lactobacillus reuteri. There is conflicting evidence for cranberries and D-mannose. That's why the grade of recommendation is not so strong for this treatment. We can consider endovesical instillation of hyaluronic acid and chondroitin sulfate or metamine hippurate. And if all of this fails, we can consider antibiotic prophylaxis, either postcoital or continuous. Behavioral modification includes identifying of risk factors such as insufficient drinking. In women who drink less than 1.5 liters per 24 hours, we can encourage them to drink more fluids. Another risk factor is habitual or postcoital delayed urination. We can encourage women not to do this. Wiping from back to front after defecation is another risk factor which can be avoided by counseling the patient. Douching and wearing occlusive underwear is another risk factor for recurrent UTI. These are guidelines for non-antibacterial prophylaxis of recurrent UTI, which says that extensive routine workup like cystoscopy or imaging is not necessary, and we can avoid it for uncomplicated UTIs. Increased water intake can be beneficial. Vaginal estrogen replacement with creams can decrease UTI recurrences. Also, immunoactive prophylaxis with OM89, as has been said, is beneficial, has proven efficacy in reducing the recurrency of UTIs. Probiotics, but only with species like Lactobacillus rhamnosus, reuteri, Kaisei shirota, or crispatus, is beneficial either by oral route or intravaginal route. The level of evidence for cranberries and D-mannose is not as high, but we can offer it to the patients and properly counsel them. There is another possibility to proceed with intravesical instillation of hyaluronic acid and chondroitin sulfate. I will talk about it later. There is a novel drug like a metamine hippurate, which transforms in acid environment into formaldehyde, which kills the bacteria which are in urine. And we can consider antibacterial prophylaxis either postcoital or continuous with the regimens which I show you in the next slide. These are the grade of recommendations for each evidence. We should diagnose recurrent UTI by urine culture. We don't have to do that in sporadic episodes, but we should do it with recurrent UTIs. And let's talk about intravesical instillation therapies. There are only randomized studies dealing with combination of hyaluronic acid and chondroitin sulfate. So the quality of evidence is higher for the combination than for hyaluronic acid alone. This is the mode of action of bladder instillation therapy. The normal glycosaminoglycan layer, which covers the epithelium in the bladder, works as a barrier for toxic substances, including potassium cations, and this gag layer prevents them to penetrate into deeper layers of bladder wall. If there is impairment of this gag layer, toxic substances penetrate into deeper layers, including bladder muscle, and they cause depolarization of nerve endings, which results in pain. That's why recovery of this glycosaminoglycan layer accelerate natural recovery of gag layer, and these symptoms gets better. This is probably the best designed randomized double-blind placebo-controlled study dealing with intravesical instillation of highly concentrated hyaluronic acid and chondroitin sulfate and its efficacy on recurrent UTIs. It was published in European Urology in 2011, and the study included patients with recurrent UTIs according to the current definition, which were stratified into two groups. The intervention arm received a highly concentrated hyaluronic acid and chondroitin sulfate. Placebo arm received saline. The dosage was to instill 4 instillation every week during the first month, and this was followed by 5 instillation 1 month apart. There were no significant differences in age, UTI frequency during the last 3 years, voiding diary and quality of life assessed according to pelvic pain urgency and frequency questionnaire and SF-36 questionnaire in patients in both arms. The primary endpoint of this study was to assess the mean UTI frequency in 1 year time, and the secondary endpoints included time to UTI recurrence, change in urinary frequency, change in urinary volume, voided volume, impact on quality of life, and incidence of side effects and tolerability. And these are the outcomes of this study. It showed that there was significant decrease in UTI frequency in intervention arm compared to placebo. There was significant delay to first-time UTI recurrence in intervention arm compared to placebo. The number of UTI during the treatment period was significantly lower in intervention arm compared to placebo arm, and the number of UTI episodes during the whole follow-up was significantly lower in intervention arm compared to placebo. No changes in voiding volume was observed. However, there was significant improvement in quality of life assessed by PUF score and SF-36 questionnaire. No severe side effects were observed, and there were just mild pain after installation in a group with hyaluronic acid and chondroitin sulfate. Antibiotic prophylaxis can be either postcoital or continuous, and these are the drugs which can be used. Fosfomycin, 3 grams every 10 days, trimethoprim, 100 milligrams every day, or alternatives in pregnancy include cefalexin or cefaclor. They can be administered, also self-administered by patients if they don't need to be prescribed on demand. This was studied in a research settings, but we all know that real-life experience is sometimes quite different. And this is a real-life setting study which includes 276 patients with recurrent UTIs, which were treated either by standard of care, which included at that time continuous or postcoital antibiotic prophylaxis, OM89, cranberries or probiotics or various combinations of these drugs. And the study included about 100 of these patients, and another group of patients consisted of patients who received intravesical instillation of highly concentrated of hyaluronic acid and chondroitin sulfate. And we found out that the efficacy in this treatment group were significantly higher than the group of patients who received the standard of care. So this is real-life experience. It was not a randomized study. That's why the level of evidence and the grade of recommendation is not so high as from the previous study. However, it is the real-life experience. We can use intravesical instillation not only for recurrent UTIs. We can use it for interstitial cystitis and painful bladder syndrome, for radiation-induced cystitis or cancer treatment-induced cystitis, like intravesical instillation of mitomycin, or any conditions which are associated with impairment of gag layer. It does not necessarily mean that only combination of hyaluronic acid and chondroitin sulfate can be used. We can achieve efficacy of lower urinary tract symptoms also by using hyaluronic acid alone or chondroitin sulfate alone. It was assessed by questionnaires like interstitial cystitis, symptom index, and border index. Thank you for your attention.